YouTube Live as we continue our best practices series to develop clinical judgment. And tonight we're going to be talking about problem recognition skills and how we can best develop and encourage that within our students. I just want you to know that coming at you from the northern suburbs here in Minneapolis, it's been unseasonably warm in the low to mid 90s. And for you that come from the south, you're probably saying, man up. It's not that bad. That's what we do for 3 or 4 months out of the year. But for us Minnesotans, that's a little bit hot. And we melt when I'm playing with my grandchildren. I don't last that long. But anyways, if you're checking this out for the first time, the goal of this live stream is really to support and serve the needs of you, nurse educators in the trenches, to empower you with practical and educational best practice strategies to prepare your students for both practice and licensure. So if you're joining me tonight, I want to say thank you because you are very busy and I am going to maximize our time together. I just want to say thank you for taking time out of your busy schedule. So let me know who's out there tonight. Give me a shout out in the chat. Let me know what state you're from, where you're making a difference in nursing education. And if we haven't met, I haven't introduced myself yet. My name is Keith. And I am the founder of Keith RN, and all that I do in my why or vision with what I do to serve the needs of educators is to lead the change that is needed to transform nursing education. We have to close this gap between how nursing is taught and how it's practiced. It has been way too big for way too long. And I really want to encourage, I really want to be a part of a movement that really is 2 words. Practice first, that we need to reclaim nursing education. It's not about the test. It's not about the NCLEX success. It's ultimately our goal, our primary mission as educators is to prepare our students for practice by using educational best practices and preparing them for the rigors of real world practice as we do that. And, I've developed many active learning strategies, unfolding case studies, practice-based frameworks of clinical reasoning that I share, as well as provide educators through many resources. And so that is my passion. And I really want to encourage all of you that are watching today to be a part of the needed change, to change culture in your program. Because how do we change nursing education? One educator at a time. We have to change the way we think. And that really begins with really recognizing that our primary focus is to prepare our students for practice. And if we implement educational best practices, and again, Dr. Benner's work from Educating Nurses is my go-to and has been the inspiration of all that I have done for the last 10 years for educators. Really the 3 simple paradigm shifts that we must embrace as nurse educators to put practice first. It's really quite simple. Number 1, we need to bring context to our content. We need to bring that context of the bedside, not the textbook. That's decontextualized. We need to bring context and real world practice realities and bringing that into our classroom, that we bring clinical into classroom by bringing case-based scenarios, other forms of active learning. But then the 3rd paradigm shift is emphasizing clinical reasoning. What I'll be sharing tonight with problem recognition skills is going to build on what we need to do to develop and to build that clinical judgment that's needed. Because what we need to remember as nurse educators, the clinical judgment that we need to develop in our students to make them safe and practice ready, as well as pass the NCLEX, including next gen, is that we need to develop that critical thinking, the development of understanding what's most important. And then we need to develop the reasoning skills at the bedside to think in action as a patient status or a case study scenario changes. And for those of you that weren't here last time at Facebook Live, I announced for the first time that I am humbled and really thrilled, and truth be told, a little bit nervous, that I will be the keynote educator presenter at the NCSBN Next Gen Virtual Conference on September 22nd. And I'll tell you, I am excited to be able to share the things that many of you are going to be able to kind of check out today, and that we're going to be talking about for the next, let me just gotta kind of get my chat going here. I just want to pop in the conference link for the NCSBN, and just excited to share the practice first principles and how we can bring clinical judgment into our classroom will be the focus, and the numerous active learning strategies and some new things that you haven't heard before. I'm saving it for the conference. And so I'm excited and really humbled to have that privilege to help and to serve the needs of nurse educators. But I want to kind of honor my audience here that's here tonight. I want to say thank you, Laura from Florida, Kristen from Connecticut, Kim from Indiana, Brittany from Illinois, Allison from Georgia, and Pam from, I think MA is Massachusetts, if I know my states, and Pat Rogers, Keith, thank you for that. Jane, we need to talk, Jane. She was a former colleague of mine at St. Cloud State, and I hope we can connect here shortly. My email is keith@keithrn.com, Jane. Love to connect with you soon. And Pat says, Benner was the foundation for my DNP novice to expert. And yes, Benner is my hero as well. And thank you for sharing that, Pat. And so who else is out there today? Alicia from Ohio, and Jody, you've been here before, from Colorado, and thank you for the congratulations. Marianne from Portland, Oregon, Destiny from North Carolina, and Vicky. I think, Vicky, you're from California. So thank you all for joining me tonight. And I just want to get started and just kind of focus today and kind of catch us up. And basically, Stacy says, will you be at the NLN in Vegas? And yes, I will. I'll be a vendor, not going to be speaking, but excited to present and just to share what I have for educators in Vegas. So Stacy, if you're there, be sure to say hello. But, I want to catch us up to speed. I come to you every 2 weeks on these Facebook Live sessions. And really, we started out talking about the clinical reasoning processes that we need to develop in our students. Really, we need to remember that the foundation of when we put practice first within our context of all that we do in nursing education, Tanner's clinical judgment model is a practice-based framework of clinical reasoning that is the foundation for clinical judgment skills. It aligns with the nursing process. The NCSBN model aligns with Tanner's, but it's not the same. Layer 3 of the NCSBN model, yes, has 6 steps. Tanner inspired every one of them, but we must remember this as nurse educators. The NCSBN clinical judgment measurement model is exactly that. It is a measurement model for clinical judgment, purely for testing and evaluation. It has no merit or research to validate the NCSBN model for practice. When was the last time you used the word hypothesis as a nurse? I haven't used it in 36 years, and I don't think you have either. That language is foreign to practice. We must not teach a measurement model, or we are going back to the problem that is present in our profession. In nurse education is teaching to the test. We have to change that culture. Tanner's framework aligns with the NCSBN framework. And I think what's really important to recognize, I'll just pop it on the screen really quickly just to show you this. But when you look at the first process of Tanner and noticing that we talked about 4 weeks ago, it aligns with assessment of nursing process. And by the way, recognize cues, the first steps of the NCSBN model, aligns with noticing as well. The interpreting of Tanner's second process of interpreting, what are you noticing as you do your assessment? What's most important? What's concerning? Then we go into interpreting, what does it mean? What's the significance? That aligns with planning and analysis of nursing process, as well as 3 steps of the NCSBN model. We just kind of broke down Tanner, but Tanner's framework has so much more because it's a practice-based framework derived from over 200 studies in the nursing literature. And so if you missed some of these prior Facebook Lives that I have done on this topic, I want you to know that you can grab them. And they are on my YouTube channel, Think Like a Nurse. And so I just want to share that link with you here. I'm just going to copy and paste if it'll let me do so. Sometimes it's a little glitchy here on my end. There we go. And so let me just pop that in the chat, and you can subscribe. And every time a new video is posted, a Facebook Live, it's there for you. So I just want you to check that out. And so anyways, what I'm going to get started with tonight, we're going to be talking. So to kind of set the table, as you look at the clinical reasoning skills, it's kind of like, think of this as like a framework, a sequential process like nursing process. We begin with, what do you notice? As you go through the medical record, as you're preparing for that patient encounter, as you enter the room for the first time, collect your first set of vital signs, your assessment, look at the lab values, the room environment. Tanner's process of noticing sets the table. What are you noticing that's most important? In essence a next-gen question. It's also a question for practice. Then we move from that to interpreting. What does it mean? What is what you're noticing mean? Oh, with the temperature elevated, the blood pressure is dropping, the heart rate is elevating. What is the significance in the interpretation of what that means? That can be fleshed out by asking the right questions, but it's also imperative to remember that your students must understand pathophysiology, or they will be unable to interpret the significance of what they are collecting. And that's why patho must be understood. It is the foundation of critical thinking. And most of our students, including educators, we struggle with it. It's difficult content, but it must be understood in order for our students to interpret the data that they are noticing in practice. And so now what we're going to be talking about are problem recognition skills. And this is where, the failure to rescue, that nursing failure to rescue, when the patient status decompensates, declines, and is swirling the drain and doesn't get noticed until it's too late, failure to rescue that can lead to adverse outcomes, including patient death, when the nurse isn't vigilant and doesn't recognize the problem, is really a failure to rescue and interpret. And I'm going to, kind of that problem recognition skills I'm going to share with you tonight are really a second tier of interpreting. Because when you interpret the data correctly, problem recognition becomes evident, and the data as it's clustered together becomes evident. And what I'm going to be sharing with you tonight is basically from chapter 4 of my student textbook. I just finished it. It just came out 2 months ago. It's a 3-volume set. The third volume is called Developing Clinical Judgment for Professional Practice. Volume 1 is laying the foundation for professional practice, talking about caring, holistic care. Volume 2 is the knowledge of the applied sciences, pathophysiology, F&E, pharmacology, practice-based assessment. And the third set is all about clinical judgment. So for fun, what I'm going to do is that I went through chapter 4 on my PDF document of the manuscript, and I highlighted it, and we're just going to go through it. In the next 20 to 30 minutes, we're just going to highlight some of the key content of this student textbook that will also help educators understand these principles. And it's already been adopted by numerous programs across the country. And I'll share some links if you're interested. But my goal today is just to help educators understand problem recognition skills as I share from this chapter 4. So let me just go ahead and do that. And I'm just going to open up my screen. But before I do that, let me make sure there's nothing in the chat. Looks great. So let me just let me go ahead and just pop that on my screen. Sometimes the technology here is just a little glitchy here. Let me just there we go. There we go. I'm going to share my screen, and so let me just enable that. And you're going to see both of us. And so what you're going to see here is the screen as well as myself. And what I wanted to share with you at the very beginning is of chapter 4, problem recognition skills. Dr. Benner, my hero, and many of yours, has a great quote at the beginning, and I quote it here. Because the patient's condition changes, and because it is the nurse who is spending the most time with the patient, a crucial part of nursing practice is detecting these changes. And so again, problem recognition is a foundation of professional nursing practice that we really want to make visible. And as I shared with you, I kind of in this textbook manuscript, I did a lot of icons. I like to have some visuals because I don't like text density. Students check out after a while. So I put some images of this is a key takeaway. Failure to rescue is caused by failing to recognize what clinical data is most important. You see, that's a really powerful quote you can use with your students right now. That failure to notice, that failure to rescue is really a failure to notice, as I shared earlier, what that looks like. And when you look at problem recognition, think of it this way. There are clinical reasoning competencies that we as educators must develop in our students to ensure safe practice. And as you know, the ACE and Essentials are all about competencies. You need to demonstrate some skills. And as you know, the skills of nursing are not just like sterile technique and med administration. There's cognitive competencies, cognitive skills of clinical reasoning that we must develop. And so when you look at an outcome that you want to put in your curriculum, in your program management for your program, the ability of your students, can they do this as an outcome? And it's there in the box. Identify possible problems, determine the current problem, anticipate potential complications, and determine which one is most likely. That's the essence of an outcome of problem recognition that we want our students to demonstrate. And so as we look at kind of a framework that I use throughout this chapter, as well as in the volume 3 set, is realizing I want you to see how nursing process of analysis, framework of interpreting, aligns with this dynamic of, in addition to interpreting the meaning of data, that's kind of like step 1 of interpreting. So we've got to understand what it means, the temperature elevation, etc. But then we have to determine, as we cluster the data, what is the current problem and what is the most likely or worst possible complication, an unexpected problem that could develop based on what they're admitted for or in the care setting for, and then determine which one is most likely. So really the problem recognition skill of interpreting is really a higher, it requires a greater level of understanding by your students. So it's not for fundamentals, it's an advanced clinical reasoning skill. Problem recognition is something that our fundamental students are not going to do. They're going to be able to notice what's most important, hopefully, as we teach that. But problem recognition requires experience and pattern recognition to put the pieces of the puzzle together by clustering related data. And that's a very nuanced and a very advanced clinical judgment skill that does take time. So as we look at this, I kind of want you to notice, what are the components of problem recognition? How do we teach it? Well, we begin with essential knowledge. It's kind of like Bloom's taxonomy. The foundation of Bloom's is, do they understand, the knowledge and comprehension? Do your students understand pathophysiology? We'll be talking about an example of that every one of your students must know in just a couple minutes, so stay tuned. But we need to remember that there's knowledge of pathophysiology as well as your essential content from your curriculum that must be understood, not memorized. But then there are skills that reflect problem recognition that we need to ensure that in our clinical evaluation, that our students are able to demonstrate these problem recognition kinesthetic skills. And really one of the beginning point, can your students do a focused and fluent nursing assessment? You see, that takes time and being able to do the focused assessment, but in essence, a fluent assessment, because the beginning of interpreting is what you notice and then interpret when you do a fluent set of assessment and you're thinking and putting those pieces together. The ability to use a concept map. Concept mapping, I love it. It helps you put those pieces together with a visual map. There's other ways to teach some of the clinical judgment skills, but concept maps do a great job of clustering data. Another kinesthetic skill is the ability to give an S-bar report or a handoff report. And this is a nuanced skill that unfortunately most students will never talk to a provider in practice. And that's a weakness. We can add that in our simulation, but we need to practice S-bar. That's why my cases that I've written from the very beginning, because they reflected practice, I was able to include S-bar frameworks and practice the S-bar when you're going to talk to a doctor, because as you know, no one's born giving a good S-bar. It takes practice. And again, there's essential thinking skills, and I'm going to focus on clinical reasoning questions, because one of the most powerful ways that we can teach a practice-based profession is asking the right questions, getting our students to think. You know, in Socrates and Socratic questioning, really look at the things that I'm sharing with you. This is a Socratic framework of developing clinical reasoning and problem recognition skill. And there's 6 questions, and you can use all 6 of them in your program with your students. You don't need to. You can simplify this, but I'm going to share them all with you to kind of give you some key questions that you can ask to develop and encourage the thinking, because that's our goal, not to spoon feed anymore. We need to develop the thinking. So here's your clinical reasoning questions. Start with this. Based on what your patient is here for, let's say that they are a patient with, let's say that they're in the hospital for post-op. They had a post-op appendectomy, and they're elderly. They're 60 years old. It didn't perf. What problems are possible with a patient post-operative with this problem? Which problem is most likely? You know, so the current problem is what it is. You know, they're post-op. But then we got to be thinking about what could go wrong, what could go south with this patient. So then we go to this series of questions. Based on their problem, what is the worst possible or most likely complication to anticipate? You see, what we must do to encourage problem recognition in our students, as well as nurses in practice, you got to be looking for it. You got to be leaning into it. You know, I'm an ICU ER nurse, so I've seen, you know, my patients can change very quickly, as you know, in any of those higher acuity settings. So therefore, as a nurse in that setting, I'm always anticipating what could go wrong, that this patient's at risk for sepsis, going into septic shock. So I have it on my radar. I'm recognizing that for this patient, even a post-op patient, they're at risk for sepsis or septic shock. They're at risk for a PE or a DVT, whatever you want, but they're all possible. So we're looking for the worst possible, most likely complication. And then we're looking for interventions that we can prevent it from happening. Now, that's not always possible. You can't prevent sepsis, but you can identify it early. But you can prevent a PE and a DVT by focusing on early ambulation, getting them moving, and all that goes with that. And so again, preventing problems must also be on our radar as we teach our students and our new nurses. Problem recognition, how can we prevent a problem or complication? The next question is, what clinical data will indicate this complication early? This is a matter of life and death, because if you know that sepsis progressing to septic shock is a worst possible or even a most likely complication, if we're looking for it early, we'll recognize the significance of tachycardia, of a trending of an upward heart rate and a softening blood pressure that doesn't swirl the drain right away. They don't go into the 70s, 60s, over 30s right away. They maintain, the body compensates for a period of time by elevating the heart rate, but then the bottom falls out. And if your nurse doesn't recognize that early trend of an elevated heart rate with a softening blood pressure, maybe just slightly dropping systolic and diastolic, if it's not noticed until it's too late, that patient will progress. And I have seen as a rapid response nurse in practice 2 patients that have died needlessly because of failure to recognize key data, one related to sepsis, one related to shock and an internal bleed, until it was too late and it didn't resuscitate successfully this patient. So this really is a matter of life and death. And this is why we need to get our eyes off of the NCLEX a lot, because when our students who graduate do not possess the clinical judgment skills needed for safe practice, the problem recognition skills for safe practice, they can harm patients and even kill them. And I've seen it, and many of you have seen it as well, or experienced it yourself at some point in your practice. And it's a tragedy, and it doesn't need to happen. Let's do all that we can to prevent that, because that person could be a relative, a family member of someone, including yours. We don't want that to happen. And so the final question we want to focus on is, what nursing interventions will be implemented if this anticipated complication develops? You know, as an ICU nurse, if I'm anticipating problems and I see it coming, I'm on top of it. I contact the provider. I raise the head of the bed. I lower the bed. I do whatever is needed depending on the situation. But this is not just for ICU and ER nurses. This is for every nurse, because every patient has the potential to go south. And we as nurses are like lifeguards. We are like lifeguards vigilantly watching our patient for a sign that there's a struggle, that they're starting to go under. Now, it's not going to be obvious, but if we notice and interpret its significance, we can make a difference in what that looks like. And so I hope you found those questions helpful, and they're in the book, and I want you to know that you can use those. These are my questions. They're in the book, but I want you to know that I'm sharing this so that you can use that. I've already talked about some of the clinical skills and SBAR, and really I would encourage us as educators, are you practicing SBAR in your classroom, in your simulation, in post-conference? Are you watching your students do a handoff report to nurse at the end of a shift? And you can't do all of them, but the bottom line is that every important skill, especially interprofessional communication, that our students don't get enough of, basically is a potential for a bad outcome. We want to develop our students and practice these essential skills and what that looks like. And so, as I've shared these questions, I'm going to ask you a question. What are the questions that you ask your students to develop problem recognition skills? These are the ones that I've basically gleaned from my 30 plus years of practice in different settings. I'd love to know what yours are, as well as kind of get a sense of what questions you have about what I've shared to this point. And so I'm just going to basically just kind of go to the chat quick, and I'll just kind of see what if there's anything out there in the chat. So let me just kind of scroll down here. And I just want you to know that if you have any questions, please go ahead and just pop them in the chat, as well as anything that you would like to share that you have done. Because really, I want this to be a dialogue as much as possible. It's very hard, obviously, when you're doing this from a Zoom kind of a webcam here in your home office, and you're all across the country, which is awesome. But Danielle says this, and I'll pop it on the screen, Danielle. I'm going to give you the platform. I asked my senior level students, what could kill your patient today? And you know what? That's that's blunt, Danielle. I love it. And I just asked it differently, but it's the same thing. What could kill your patient today? And you know what? I love that, Danielle, because you're being real. And as we know that, if we miss something, it can kill. We look at sepsis. You look at those common complications that we see most common. It's kind of like it's like a most common worst possible piece. And so again, looking for it. What could kill your patient today? And then, Danielle, add to that, how will you notice it early? If you know it's sepsis, if you know it's this, if you know it's that, depending on your setting, What will you do to recognize it early? What are the early signs? And that's one of my clinical reasoning questions of problem recognition. But again, it's a practice question that all of us as nurses use I think this is just intuitive with experience. And so I've got another question here or another statement. Tina says this: what would cause them to die the fastest way? Now, usually some of these complications are progressive. Sepsis to septic shock, that takes hours. What's really fascinating is you look at the literature of failure to rescue and patients who decompensate. Only about 10 to 20% max suddenly go under. 80% plus decompensate to the point of coding over the period of 12 to 24 hours of decline. So therefore, we usually have plenty of time. And if we don't, it's not on us. But because the nurse, like Dr. Benner says, is at the bedside 24/7, it's on us to notice that. Notice those subtle decompensating trends. And so excellent. And Dixie says this. She says, need to add that. What are the early signs? Dixie, that's awesome, because I've seen in practice when I get that rapid response call and it goes overhead, as you know, if you work in acute care, sometimes the bottom line is that the nurse at the bedside, I can say in a lot of the rapids that I was a party of, they recognized a problem way too late. When I would look back at the chart and see the decompensation as an experienced nurse, I saw the heart rate elevating, the blood pressure softening, and now they call a rapid response when the patient's blood pressure is 70/30. That's too late, and sometimes they don't survive. And so again, early recognition, early assessment findings. And so really one of the things that I want to encourage you all to do as educators in your clinical practice setting, where you have clinical, identify for your students what are the most common complications in this setting. If they're post-op, surgicals, we know that sepsis, internal bleeding are always a potential problem. But then you ask that next question, like Dixie says she's going to add. So again, never stop improving as educators is my motto, and I hope it's yours. Then its bottom line is asking, what are the early signs? What are the early signs of sepsis? What are the early signs of a PE? Early signs of internal bleeding, etc. And so asking that. And so again, well done, and thank you for doing that. Well, I'm going to continue here. And if you have other questions, I'm going to keep the chat. I'm going to kind of keep that on there, and we'll definitely keep an eye on that. And I'm just going to kind of go into the next, let me just continue my journey here with going through the chapters. So let me just share my screen one more time. And let me just go to there we go. Awesome. All right. So what I'm going to go to next is just looking at, I've already talked about the importance of identifying what's most important, looking for complications, being a lifeguard. Just kind of an FYI that I thought was kind of fun. I work at a very large metropolitan area. And the rapid responses that they kept track of the data. In the acute care setting, there were 5 most common reasons for a rapid response. Now, this is not global, but this is just one very large sample size that I think represents the essence of what other hospitals also would have. But the top 5 are chest pain, respiratory distress, difficulty breathing, decreasing SATs, hypotension, change in neurologic status, stroke, or other aspects related to maybe narcotics, etc., patient fall. And so again, as you look at some of the problems that we want to be anticipating as nurses, these are acute care, the most common in one setting, but again, we can use it as a general guide and kind of talk about really when you look at chest pain, for example, I'm not going to go into this at length, but as we know, not all chest pain is cardiac. How do we flesh out cardiac versus non-cardiac chest pain? And how can we as a nurse be confident of some of those judgments? I talk about that at length in these pages that follow. I'm not going to go in that, but I talk about some of the key takeaways of respiratory distress. A couple things I want to share with you that are really important. Did you know that respiratory rate is the first vital sign to change with a complication of a declining change of status? A lot of people think it's heart rate, but actually it's the respiratory rate that is the most sensitive indicator. Usually it's a respiratory rate that's increasing over the rate of 18. If they are trending upwards subtly with their respiratory rate, the earliest sign of decompensation. But in this practice pearl, I highlight some interesting data. Did you know that the respiratory rate is the least accurate set of data in the vital signs of a medical record? Because to do an accurate respiratory rate, it's not just eyeballing it. It's not just doing it for 15 seconds. To be accurate, a respiratory rate should always be done a minimum of 30 seconds. Preferably 1 minute. And if you are kind of breathing with the patient, you can identify if there's some like an irregular or abnormal patterns of breathing by just doing that beneath the radar as your patient's doing it and counting minimum 30 seconds, preferably a minute. We must be teaching our students that because respiratory rate is the first to change. If we just eyeballed it and didn't really kind of just guesstimate it or did it for 15 or 10 seconds, that's all too common in practice, or we didn't validate it. A lot of times respiratory rate and vital signs are done by assisted personnel. They don't know that they should do it for at least 30 seconds. We got to validate our numbers, make sure it's accurate. So again, that's a really important takeaway that I hope you remember from this Facebook Live, the importance of respiratory rate and problem recognition. This is one thing I want every one of your students. I want you to drill this in them as an educator, this application of this pathophysiology principle. Cardiac output equals stroke volume times heart rate. Your students may have memorized that. They have no idea how it applies to problem recognition. And what I share in my next little statement here of a key takeaway, elevated heart rate is the first compensatory response to shock, while a low blood pressure with an elevated heart rate is a later finding. Your students must understand that the body will compensate this formula, stroke volume times heart rate. If they understand that the body is going to compensate to maintain cardiac output by increasing the heart rate when a volume depleted status is present due to septic shock, dehydration, internal bleeding, then the elevated trend of a heart rate will be an immediate red flag. And so we need to make sure that our students understand this formula of pathophysiology and apply it to practice. You see, it's not just about memorizing the content. It's about understanding it and applying it to real world practice. And that's where we need to drill deep and emphasize with our students. And so again, making sure do your students understand that formula and what that represents. So I talk about neurologic status, falls, and then again, highlight these same questions. It's kind of at the end of the chapter now, and I kind of now have an application activity. Let's use, I always want to bring it back to practice with this textbook that really just keeps it real for students. So we have Zanae Young. She's a 9-year-old African-American girl who presents to the emergency department after the school nurse called her mother. She has a history of asthma, diagnosed at age 6, has 2 prior hospitalizations. She began complaining of chest tightness and feeling winded after recess at school today. She is alert, sitting upright, speaking in short sentences with an O2 sat of 91%. She complains of increased chest tightness and uses her accessory muscles to breathe. She has coarse expiratory throughout both lung fields with decreased breath sounds at the left base. She has moderate intercostal and substernal retractions are noticed and appears anxious. So we want to stop right now. And I want you to see the genius of Tanner's framework of clinical judgment. What do you notice that is most important? Or you could say this to your students. What do you notice that is most concerning in this scenario? Do your students understand your content, that they would recognize the clinical significance of an O2 sat of 91%? Is that good or bad? What about the accessory muscles, the wheezing, the decreased breath sounds, the retractions? See, that's a clustering of data that as you get experience and you apply your knowledge to practice-based scenarios, we can now begin to kind of say, there's a problem here. There's respiratory distress. This is not just like, oh, she's got, difficulty breathing. She's got some signs where she's struggling to breathe. She's like a swimmer going under. And we've got to recognize that as a nurse. And so again, this is a great opportunity to pause, use tenors. What do you notice that's most important or concerning? What does it mean? What is the meaning or significance of retractions, of the wheezes? What's going on at the bronchioles? Why are they wheezing? Well, don't assume your students know it. Let them communicate it to you, that they really do understand this essential knowledge. So now we go to a set of vital signs. We get that initial data. And again, look at our current set of vitals. And what I did here very intentionally, we use EPIC in the Twin Cities area, wherever I've practiced as a nurse in this area. It's also the dominant EHR. I didn't make this to look like a next-gen framework of just recipe cards. I basically used the framework of EPIC, which is pretty typical with most EMRs. So again, to help your students kind of get, again, a practice-based perspective of how they're going to view the content in the medical record. So you can see the most recent set of vital signs at 1840, heart rate of 134, rate of 32, blood pressure 1/64, 92% SATs, face basket 2 liters. And then looking at the diagnostics, we can see that the current CBC, again, it looks like EP, it looks like an EMR, not just a bunch of data on a recipe card, which is what I've seen with the NGN style. So again, our CBC doesn't look too bad. Our basic metabolic panel has nothing concerning. The X-ray has hyperexpansion. And again, is that expected or unexpected? That's a great next gen question. It's also a practice question that is expected with asthma. But again, as we look at our vital signs, not a dramatic change, but this person is breathing, the heart rate is going up, the rate is going up, SATs, 91, 92, a 1% difference. But look at the differences with oxygen, and it's still not that improved. It's still too low. That should be 95%. In a child without COPD, they should be 95%. So again, we can talk about that, guide that. And so now we have a simple case-based scenario. And one of the things that I'll be doing at the NCSBN conference, I'm going to show educators how to write easily case-based scenarios. There's a little bit of a secret sauce to it, but it's not difficult. If you can write a paper, you can write 1 or 2 paragraphs of a salient scenario. But again, you have that scenario, and now you're going to ask these clinical reasoning questions as it relates to Zane. And what we've seen with this minimal data, just like a next gen, really this is in essence a next gen, but it's not next gen. It's developing the reasoning that will prepare them for practice. And by the way, next gen as well. So the first question, what problems are possible? Well, we look at Zane, we look at her respiratory, we kind of look at, respiratory distress is probably the current problem, and which is obviously most likely. But what's the worst possible and most likely complication with Zane? You see, right now she's struggling. What if she continues to struggle? We're talking respiratory arrest. We're talking respiratory failure. We're talking about the need to intubate if she doesn't improve. We've got to be one step ahead, recognizing where's the crash cart. If patient continues to decompensate, if she doesn't respond to the nebulizer, for example, doesn't respond to the second, we've got to be always thinking that this patient is not coding yet, not in respiratory distress yet. Well, it is in distress, but not in arrest. So again, what interventions can prevent this complication from developing? And again, vigilant monitoring, frequent assessments every minute, every 5 minutes, if you're in the ER or, in that kind of setting, which is where she is right now. And again, trending vigilantly. That nurse can notice a trend very quickly and respond. What clinical data will it indicate the complication early? Well, we look at decreasing SATs. We look at increasing respiratory rate, increasing heart rate. Despite oxygen, not oxygenating, they're still in the 80s, for example, etc. What interventions will you implement if the anticipated complication develops? And again, being one step ahead, know where your people are, that if the patient does decompensate to a very level of distress that could lead to an intubation, get your people in play and what that looks like. And so again, we can't always prevent the problem, but we can identify it early and respond by being proactive. You see, this is where life and death is really impacted in this context, because if you are reactive as a nurse, you're going to be flat-footed, slow on your feet, and you'll recognize it too late. But if you're proactive, leaning into this patient, leaning into what's possible, always asking what is the worst possible, most likely problem that could develop, you're going to lean into that and you're going to see it early if it develops and respond immediately. And that's where a nurse is a superhero and makes a difference and saves a life. And that's what we want our students to be, because they're entering practice at a very difficult time. The pandemic is still lingering, though that affects, but the short staffing, the challenges of practice remain. And we're in a crisis in nursing education. We're still teaching to the test. We're not bringing practice enough. We're not bringing active learning consistently. And it's my passion to empower you to change that for those that have ears to hear. And so I just want to thank you for just bearing with me through that. And I hope you found that really helpful. And so I just want to get some questions and feedback as we wrap it up and have a chance for those that are attending live to be able to answer your questions and put it together. And so I'll just go through. I got about 5 of them here. So let's go through these. Allison asks, what about teaching these skills in more community-oriented settings? And Allison, absolutely. You can take any scenario, and I would encourage you, this is where I want to empower educators to write your own. Where are your students practicing in your community? Is it home health? Is it transitional care units? And being able to take the same information at a level where a patient in that population would present with the problem. I wouldn't call it a weakness, but my bias is that I have been in acute care almost all my career. And so, that's where my orientation goes to first. And so I'm in the process of actually rewriting my current case studies in the membership, and I am going to be very intentional to have increased diversity, increased settings in the community, and not ER and acute care, which where many of them are today. So I'm going to do that differently, but I would agree with you, Allison. Include that. See, I want to give, you have the ability to write these scenarios and to do that. So please do that in what that looks like. Allison also says, what about some less serious data that still nevertheless requires some action? Absolutely. I'm just kind of showing you an example of what I've written in this book, in my textbook, but absolutely, Allison, this is where you, as an educator, put on your practice hat, put on the practice lens, and think about some of those scenarios that you saw that were ambiguous, but yet were significant. You see, students are concrete, task-oriented learners. That's better as novice to expert in a nutshell. Therefore, we have to move them from the task and from the concrete, that there's ambiguity in practice. Our students don't like it, but they need to be exposed to it. And so, Allison, that's where you can bring your case-based scenarios, can make that bring that reality into your setting. And so again, and you ask the same questions, what about problems that are not so dire? And I agree, Allison, you can, again, make this fit your course objectives, your curriculum, and the level of your students. And so again, whatever that looks like, you can create those scenarios and just taking the experiences of your stories in practice and make it possible. And so I've got a couple other comments here. Renee says this, I love this. Just because it's taught doesn't mean it's understood. Let them walk through the process of critical thinking. And you know, Renee, you tied on a very important point. Potter and Perry's Fundamentals of Nursing has the best definition of critical thinking. In my opinion, it's the ability of the nurse to act on what they understand. And you know what? That understanding your content is essential to develop that thinking and the application to reason with it in practice. So again, thank you. And Vicki says this, do you have a template for the EHR you showed? Vicki, I don't currently, but as I revise the membership over the summer completely, which is what I'm doing right now with my case studies, I'm rewriting, revising, updating, adding new tools, revising tools, I will have a revised electronic health record, just like you saw in a Word document for faculty inside the all-inclusive membership to easily create a salient EHR that looks like an EHR, not a next-gen test item. Because again, practice readiness is our goal, and that will be available if you're a member. So I just want you to be aware of that. I'll take some questions, but I'm just going to close with just a couple of things I just want to share with you all. Number one is that I want you to know that I have some resources I'd like to share with you. Number one is that I happen to have a little. Let me find that right here. I have an excerpt. I'm going to share it with you right now from Volume 3, the volume that I just did on problem recognition. I have an intro and a portion of, I think, Chapter 1 that is a PDF download. If you just want to kind of see and get your head around what is in the third volume, what I want you to know is that, you know, with the 3-volume set that I've written, they complement each other. And really, some of you are familiar with my prior second edition, Think Like a Nurse, Practical Prep. It was about 300 pages and was 6 to 7 years old, written in 2016, 15. What I did with my PhD journey, I expanded the knowledge that I grew with my doctoral studies, my experience in nursing and nursing education, and I realized I wanted to expand and strengthen that edition, and it kind of morphed into 3 complementary volumes. And so to kind of give you a sense of what I've developed, you know, Tanner's framework talks about the importance of caring and holistic clinical judgment, that you have to care like a nurse to think like a nurse, that caring, presence, engagement matter. So in Volume 1, I talk about holistic care, professional identity formation, incivility, and being civil and respectful in practice, as well as student success strategies written by experts. It's about 170 pages, 6 chapters, very concise, a great foundations or fundamentals resource meant to align what my textbooks do in this new version, which the second edition also did, provides a practice-based perspective of essential knowledge. And this is really, I think, the missing link in nursing education. We've got our textbooks are this thick and lots of information, but it's decontextualized to practice. If you noticed in what I shared with you of Chapter 4, I had practice pearls, key takeaways, scenarios from practice, bringing in the knowledge that the essential need to know knowledge of practice. And then I kind of built on that with Volume 2, developing the critical thinking, the knowledge of our profession and understanding it, talking about pathophysiology concepts, not all 70 or 80 of Giddens, but about 15 of them, like perfusion and ventilation, oxygenation, immunity, inflammation, etc. And had an expert faculty write that. Then going into pharmacology, fluids and electrolytes, and practice-based nursing assessment. We teach way too much assessment skills. We got to simplify it. I talk about that, use the nursing literature to guide that. And that's Volume 2. In volume 3 that we just talked about is clinical judgment for professional practice. And again, the different clinical reasoning skills of Tanner's framework, also that align with next gen, the noticing, interpreting, problem recognition, etc. And so I just want you to know that this resource is one that you as a faculty have found. I've gotten some incredible feedback from faculty who just found it helpful for them to kind of put it all together and what that looks like. And so it's something that can also be, my primary goal is to get this in the hands of students. And so as either a recommended or an adopted resource, it's affordable. It's not as expensive as you would think. And I've got it in ebook, audiobook options, and got a couple links there. If you'd like to learn more about the books, again, check out the link. I also have a curriculum integration map and what that kind of how each volume aligns with some core content within your program. And so the bottom line is, if you just want to kind of get a sense as far as, what could align, what could possibly replace or complement. And then if you'd like to consider adoption, I have a no obligation form. Again, just check it out. If you'd like to learn more, I'm always available. And if you have questions, my email is real simple. It's just keith@keithrn.com. And so in closing, I wanted to also just kind of let you as faculty know that one of the struggles that I saw as a new educator was the ability to really develop clinical judgment in my students. And so one of the things that I have worked tirelessly with is helping you kind of provide a number of resources for educators. And I've got on my website, keithrn.com, I've got blogs and articles on every topic under the sun. That is free. And they're yours there's lots of links, lots of information. So if you'd like to dig deeper on some of the things that I'm sharing today, go to my website, go to the resources page, and I've got numerous articles. I also have a store. I just want to highlight 2 of my top selling resources that are affordable and will help you build on this. This one here is titled Faculty Guide to Develop Clinical Judgment. It's taking the essence of my dissertation on the topic of unfolding case studies and developing clinical judgment using Tanner's framework and its alignment with the NCSBN, and helping faculty understand how to implement meaningful active learning that develops clinical judgment using case-based approaches, clinical practice scenarios, how to bring that into the classroom in the clinical. And the one that I wrote about before that is called Teach Students to Think Like a Nurse. And that's also on the store. And that's a resource that is more comprehensive, about 300 pages, but again, goes into some very down-to-earth strategies on developing clinical judgment in the classroom, in the clinical, in simulation. If you're a new educator, it's kind of a real-world nitty-gritty that will empower you to really understand these key concepts that I'm sharing with you in these Facebook Lives and what that looks like. And there's also some what I developed way back while I was early in my journey were unfolding case studies based on Benner's work, and those are also available for purchase individually. I only have about 15 topics currently in the store. But really, if I could encourage you to look at one resource I have, it's really my best resource. It's the all-inclusive faculty membership. I've got 110 unfolding case studies of different levels of complexity, skinny reasoning for the classroom. It's 4 pages long, uses Tanner's framework. Every aspect of the questions capture the essence of what I've shared today. They're open-ended, no multiple choice guessing. You either notice or you interpret or you don't. My first 2 questions are always in my cases. What do you notice that's relevant or most important in this scenario? For example, what is the clinical significance? What does it mean? And again, I was bringing Tanner's framework and next-gen thinking 10 years ago when I first wrote these. But I have now about 110 topics, different levels of complexity. I have about 20 hours of webinars for faculty development with contact hours. And so I've got that inside the membership. So if you're needing to develop clinical adjunct faculty or yourself as an educator, you can just get 30-minute webinars with contact hours, and they're just right there for you, as well as numerous tools and some of the things that I'm going to be adding as it relates to the electronic, an EMR focused that's reflecting practice, clinical judgment tools for classroom clinical. There's a lot there. If some of you are members, if you put anything in the chat just to shout out what you're finding helpful, please do so. But anyways, that's what I have. And I'll just kind of close with this thought that if you have any questions, please email me. My email is, I'm available to any educator who has a question. You don't have to buy my stuff. I'm not even here to sell my stuff. I'm just making it available to you. If you found what I shared helpful, I have other resources that are helpful to serve your needs and those of your students. And so don't hesitate to reach out. I will be back in 2 weeks. We'll be talking about the next step of clinical reasoning and nursing assessment is planning and prioritization skills. Whenever you prioritize, like what does the nurse do first? That's a clinical reasoning skill. And it's all over the NCLEX, but it's also a practice skill. So how do you develop those responding or the nurse planning skills? And keep it simple. We don't need 10-page care plans anymore. Let's make that a no-no and a taboo. I'll show you how to do that and some of the lens of bringing practice. But before I go, I've got a couple of questions here, and I'll just, Renee has this question here. At any point, did you use the practice analysis statistics to help with important practice areas? Now, Renee, I'm not quite sure you're referring to the NCLEX practice analysis statistics and what practice areas are you referring to it? When I talked about kind of looking at the settings of the cases that I will be revising, I'm going to be using it to be much more inclusive, just in generalities across the country where nurses are currently practicing. Only about 30% are going into acute care. It's not 30 to 40, depending on where the where your practice area is, if it's metropolitan or not. But again, we have to prepare our students for all of the diversity of community settings and tertiary settings, etc. So if you want to clarify that, please throw something in the chat here shortly, or we're going to be winding it down. And Carrie just says, thank you for sharing all you do. And again, it's my pleasure. And again, what I would say to you, Carrie, thank you for all that you're doing, because really what I do with Keith RN is a partnership. And it always is, however you just even coming tonight, listening to me, there's a partnership and an engagement that I really, that I can't make a difference unless educators in the trenches jump and run. It's kind of like a baton toss. It's kind of like a baton. You know what? I'm just here to give you the baton, and it's my hope and prayer that you'll take it, you'll run with it, and you'll do what's needed to take it one step at a time on your journey. Because again, I believe wholeheartedly we can transform nursing education. It's not hopeless, but we've got to be willing to change the way we think and the way we do things. We've got to eliminate TWIDA. The way we've always done it has got to go. We've got to bring active learning, case-based scenarios, case-based curriculum, practice realities. If we do what Dr. Benner told us to do 12 years ago, we'd be in a much better place. And so I'm just carrying Dr. Benner's baton, and I'm going to take from Dr. Benner. It impacted me, and now I'm handing it off to you, every one of you who are listening to this, either live or in person. I just want to say thank you for just seeing the value in what I'm doing. And I'm so thankful that Phil Dickinson and the NCSBN is also recognizing the value, because I've always felt kind of like an outlier. I haven't been that accepted by a lot of people in the trenches of academia, as well as by my professional colleagues in nursing education. It's been a really kind of a broken road. I'm not going to go there. But the bottom line is, it's just a really encouragement to me to have you all here today, to be able to serve your needs. And I just want to say thank you for all that you're doing to make a difference, because you're the hero. I'm just kind of serving you on the back end, and you're on the front lines, taking the hits. And it's my goal to give you the ammunition that you need, whether it be strategies or tools, to continue to make a difference. So thank you so much for your time tonight. Have a great evening. Enjoy the summer. We all need rest and restoration. And I'm kind of a type A driven dude that struggles to do that. And I've got to learn my limits, and I'm going to do my best, but I want you to do the same. And enjoy the summer, get some needed rest, and be strong in the fall. And I look forward to connecting with you in 2 weeks. And thank you again for joining me. Have a good night. God bless. Good night.